Okay, Rick, let's get started. Okay, well, welcome to PCEP for May. I'm glad I could be here. That's an in-group joke, which we could get into later. Today we're going to talk about respiratory management of respiratory problems, respiratory diseases, sort of an overview. We'll have some case studies, case reviews. Marlo and Marty will do the case reviews. And then this is in preparation for next month's skills sessions, which will be primarily, entirely devoted to management of respiratory diseases. Now, we will talk a little bit about congestive heart failure, but it's not the primary thing, because although they may be short of breath, it's not a respiratory disease per se. But we will talk about that a bit. A couple of caveats right off the bat. Obviously, basic principles in managing respiratory disease: maintain the airway. If you have trauma, protect the C-spine. Any patient with respiratory distress should receive oxygen. Any patient suspected of being hypoxic should receive oxygen. If you suspect them to be hypoxic, check their SpO2. If their SpO2 is less than 94, they are hypoxic. Now that means, the simple thing then, that means if the patient is not appearing to be short of breath, they're having what you think is a STEMI. They're not short of breath. Their SpO2 is 96. They don't need supplemental oxygen. And if they're having a stroke, they don't need supplemental oxygen. In fact, supplemental oxygen may be bad for them. So, also, a caveat: a trial of CPAP may be appropriate for any etiology of dyspnea. Okay. Now, okay. Straightforward stuff. Upper airway obstruction, common causes. The tongue, of course, is your number one enemy in the unconscious person. Then there's foreign matter, trauma, burns, allergic reactions, reactions to things like ACE inhibitors, etc. Your assessment: differentiate the cause, treat the underlying cause. If they have partial obstruction, oxygen. If they're dyspneic, sit patient up, have him cough. Transport if the obstruction is not cleared, or if you're suspicious of aspiration, of course. In a complete obstruction, I'm not going to go through the American Heart Association protocols. It's all pretty straightforward. We will practice that in our airway sessions. In an unconscious person, you, of course, can use a laryngoscopy to attempt to remove with the McGill forceps. If the obstruction is not, if you can't remove an obstruction and you're unable to ventilate, and consider a cricothyrotomy. We will not practice cricothyrotomy in the skill session, but we're going to set that up as part of our advanced airway, as part of our PCEP skills over the next few months. We have a new approach for some of this, I think. Now, in a child, we don't do a cric. We could try a needle jet insufflation. I don't think you should use a needle jet insufflation on any adult. It doesn't work. Go to a cric. And of course, transport to the closest hospital if you're having respiratory obstruction, respiratory issue. Okay. Now, the real meat of our respiratory management is in dealing with the adult respiratory distress syndrome, there's a lot of things to consider in adult respiratory distress. The basic underlying thing with adult respiratory, or ARDS, or acute respiratory distress syndrome, depending who you read, is pulmonary edema. Now, I don't know why it does that either. Now, pulmonary edema can be caused by, well, the basic problem is of increased interstitial fluid. Now, that can be caused by two sources, basically. Increased vascular permeability, so the capillaries, the alveolar capillary leaks because of injury to it, and you get increased vascular permeability and increased fluid interstitially, or you have increased hydrostatic pressure, which means that the heart isn't pumping forward and you're getting increased pressure in the venous system, and then you leak fluid into the interstitial space. So that's, classic cardiac pulmonary edema. But the bottom line is, for whatever reason, you get increased interstitial fluid or decreased fluid removal from the interstitium, same thing turns out, and then you end up with decreased ability to have CO2 go from the capillary to the alveolus, so you have decreased ability to excrete CO2. And you have decreased ability because of the size of the interstitial space. Oxygen has to go into that and then be transported across, and it takes increased time, decreased oxygen transport. So you end up with hypoxia and increased CO2. Now, this can be cardiogenic or non-cardiogenic in origin. Cardiogenic, straightforward, increased hydrostatic pressure forcing fluid out. Now, if the patient is metabolically challenged already, in other words, an older person with decreased albumin, a cirrhotic with decreased albumin and proteins, there's less protein, less oncotic pressure in the capillary. So if you increase the hydrostatic pressure backward, you then can leak fluid faster. So older people are more at risk. As we get older, we all decrease our albumin content. So it's decreased oncotic pressure, so you're more likely to leak into the interstitial space. Hence, more congestive failure as we get older. Cardiogenic congestive failure. Now, the non-cardiogenic causes are more than the cardiogenic causes by far. Now, the big ones are sepsis. Now, aspiration is there, but the patient basically has a septic condition going on because of the aspiration pneumonia. Pneumonia, pulmonary injury from any type, burns, inhalational injury, oxygen toxicity itself damages the alveolar membrane, damages the capillary, and it leaks. Drugs. One of the most common ones we see is it will be narcotics, narcotic overdose, then treated with Narcan. There's a fair number of people who end up with a non-cardiogenic pulmonary edema after that combination. Now, I'm not clear, and the studies aren't clear as to whether you take the narcotic and the Narcan, because I don't think you can get pulmonary edema from Narcan alone. Of course, why would you give Narcan for fun? Well, we do sometimes. We have an unknown unconscious respiratory depressed person, and you give Narcan by protocol. A lot of them don't wake up. They don't get better breathing because it really wasn't a narcotic. But they don't necessarily develop non-cardiogenic pulmonary edema. The near-drowning syndrome, you get someone who's been immersed, has a near-drowning episode, they're resuscitated at the scene, or they self-resuscitate, and then within 15 minutes to an hour, they develop non-cardiogenic pulmonary edema. Head injuries are characteristic of they develop an ARD syndrome, an adult respiratory distress syndrome after head injury, probably due to the effect of neural damage and release of everything from endorphins to serotonin and things like that. Pulmonary emboli, tumor destruction, patients being treated for cancer of the lung, patients being treated for leukemia, patients being treated for other soft tissue cancers as the tumors, they're toxic things released that have a negative effect on the alveolus. Pancreatitis, any shock syndrome, and look at the very last one, cardiac arrest. Multi-organ failure with after cardiac arrest, including adult respiratory distress syndrome. Very high mortality with ARDS because it goes on to the sepsis shock syndrome to multi-organ failure. The basic problem, though, is it starts out with your interstitial fluid increasing, which disrupts diffusion and perfusion. So, in your assessing the patient, my assessing the patient, symptoms are related to the underlying cause, so dyspnea, confusion. Simple way to look at confusion is confusion often means increased CO2. Hypercarbia causes confusion and lethargy, ultimately coma. Agitation means generally hypoxia. So you can have both agitation and confusion leading to coma. Abnormal breath sounds, rales, ronchi, rales or crackles now, and nowadays we had to come up with a different name. How do we manage the adult respiratory distress syndrome? Okay, your underlying condition first. So if you're into if the patient has, for example, toxic gas exposure, closed fire, upper airway problems, as well as lower airway, developing the respiratory distress syndrome, you're going to manage that upper airway first. Patient has burns about the face mouth. You're going to intubate that patient, make sure that they don't obstruct from edema. Then support respiratory effort, positive pressure ventilation. Now, the underlying treatment of all adult respiratory distress syndrome, increased interstitial edema, is positive pressure breathing, whether it's cardiac in origin, whether it's non-cardiac in origin. So positive pressure ventilation can be done with a PEEP valve on your BVM, can be done by CPAP, or it can be done by intubation and providing positive pressure. And you just you start out from the easiest one, the one that the patient will most tolerate. Now, if it's in the case of our burn patient, not a problem. RSI them, intubate them, and provide positive pressure ventilation. Obviously, monitor cardiac rhythm. Medications, we don't really carry a lot of medications that really make a lot of difference. Now, if the patient is if this is cardiogenic in origin, nitroglycerin, Lasix may be indicated. Lasix is way down the line now. It's not a first-line drug anymore. CPAP and nitro would be your first-line drugs. If the patient wheezes, my basic rule is, if it wheezes, treat it with wheeze medicine. If it's cardiogenic, albuterol makes pulmonary edema better. Studies are clear about that. If their underlying problem is a respiratory pneumonia / with an allergic component, and if it's wheezing, they get better with wheeze medicine. Now, albuterol is your drug of choice. If you use, you can put Atrovent with it, but it's the albuterol that does the work for cardiogenic pulmonary edema or for non-cardiogenic pulmonary edema. Now, corticosteroids, if you think it's an allergic component, you know, I have a basic rule, no one should die without steroids, but there's no clear evidence that it makes any difference, at least at the doses we use. I mean, people have tried magnificently large doses of steroids, you know, in the many grams of steroids. Okay, so basic rule then, adult respiratory distress syndrome, treat the underlying cause. If you can, address wheezes, address pulmonary edema with positive pressure. Obstructive lung disease. Flavors are emphysema, chronic bronchitis, which are basically the chronic obstructive COPDs, chronic obstructive pulmonary disease, and asthma. Contributing causes to COPD, genetic disposition, which we can't do anything about. You're born with that. You can't alter your genetic. You can alter your exterior, but you can't alter your interior, the gene. Some people should not smoke because they are guaranteed genetically to develop emphysema and or lung cancer. So the basic rule, unless we had a genetic marker for it, and you can say, hey, I don't have this, so I can go ahead and smoke, you still have a risk of developing, even without the gen. Some people are more prone to it. That's why there are some families where many people have had lung cancer. Now, there's also most emphysema and most chronic bronchitis is due to smoking. So, including secondhand smoke. My aunt ultimately died of emphysema and lung cancer. She was a nurse. She also owned a bar. and her husband always blamed the secondhand smoke at the bar for her underlying lung disease. Of course, she did smoke 2 packs a day anyway, so that was a combination of the two. Smoking, secondhand smoke, etc. You get enough exposure, and then occupation exposure. But you know, so if you're a coal miner, if you work in the the asbestos industry, and if you work as a miner in mining uranium, you have high risk for development of emphysema and other underlying lung diseases, including cancers. And radon fits in there too, you know, which makes me happy every time I sit at Station 1 and watch the radon detector. Yeah. You have to be exposed for a reasonably long time. Now, the basic pathophysiology of emphysema, if you have the genetic disposition or not, is exposure to noxious substances, and that could be tars, that could be hot gases alone. There's some suggestion that even with people who are switching now to the vapor devices, still are at risk, going to be at risk for emphysema and other things on the basis of the hot gases. Emphysema is simple. You get destruction of the walls of alveoli and scarring. It increases your residual volume, non-air exchanging. There are compensatory mechanisms your body tries to make to increase what you're doing is you're losing surface area for diffusion, and your body tries to do compensatory things, increasing the size of your chest so you have more surface area. That's a losing proposition generally because your chest wall gets to a certain size. One of the big problems with emphysema is you end up with, because of the scarring, you get increased vascular resistance to flow. So the right heart has to develop, it has to overcome pulmonary hypertension. You slowly develop pulmonary hypertension, and the right heart begins to hypertrophy. That's the normal. That chronic hypertrophy of the right heart in response to increased vascular resistance, pulmonary hypertension, develops what's called cor pulmonale. The right heart becomes almost as big in some cases as the left heart. That decreases the internal size of the right ventricle, so it makes it more difficult to pump a large volume forward. So with cor pulmonale, they have increased pulmonary hypertension, and they show all the signs of right heart failure, which are jugular venous distension, increased venous pressure. So you have what you call a hepatojugular reflux, which is a kind of interesting thing. You push on the liver, right upper quadrant, and the veins distend because you're getting a push back. You're increasing that pressure. That shows you have increased venous pressure. Because of increased venous pressure, you almost always have edema of the extremities too, because the veins are under increased pressure, and you begin to leak to those fluids too. Develop polycythemia. Often polycythemia means your red cell count goes up because one of the compensatory, if you're not getting enough oxygen through your lungs, one of the ways to compensate for that is to increase the red cell count to carry more oxygen. So polycythemia. Problem with polycythemia is thicker blood moves with more difficulty. It clots quicker because it moves sluggishly through lung surfaces, so they're at much more risk for clotting problems, deep vein thromboses, more at risk for pulmonary embolus, etc. And more at risk for heart attack. Heart has to work harder. Increased risk of infection, dysrhythms. So, just illustrative of this, healthy lung, lots of alveoli, translates to lots of surface area for exchange. Healthy lung, you can get along with one healthy lung. We used to do that all the time. For tuberculosis, we'd take out a whole lung. Don't do that anymore, but take out a whole lung, and if the other lung was healthy, the person lived, just fine. COPD, you just don't have the surface area for diffusion, and you don't have the vascular supply, so you have a problem with diffusion and perfusion. So, physical exam, barrel chest, the compensation for loss of alveoli. With that barrel chest, it's usually affixed. It doesn't, they're diaphragmatically breathing now because their chest is out to the size it can just about maximum size. The problem with chronic bronchitis and emphysema also is that not only do you lose the alveolar space, but because your air sacs are bigger, although there's less surface area, they're bigger, and you're trying to, when you try to exhale, that has a tendency to collapse and narrow the bronchi and bronchioles. So the characteristic of emphysema is your expiratory phase is longer. You see that on your, you can see that on your CO2 on your capnography. The expiratory phase is long. And then that means the rest phase is short. So if you watch a COPDer who's in trouble, who's having some respiratory distress, long exhalation and a very short time before they have to inhale. So they lose the rest. So that's one of the reasons they tire out. The respiratory rate's up, but it's a short rest period. Thin. If you don't have enough oxygen, you can't support enough circulating oxygen. You can't support a lot of tissue. So they have a tendency to get thin. Pink skin because of the extra red cell, the polycythemia. Hypertrophy accessory muscles, which come into play when they get really short of breath, when they're really respiratory distress, they start using strap muscles to breathe forward. They have a tripod and use the strap muscle. Chronic bronchitis results from increase in mucus-secreting cells in the respiratory tree. That's a response to the noxious substance, noxious stimulation, whether it's from cigarette smoking or whatever. The alveoli themselves are relatively unaffected. Now you can have both chronic bronchitis. You can get the double whammy, chronic bronchitis and emphysema together. There is, however, decreased alveolar ventilation because of the increase in mucus-secreting cells and the narrowing of the bronchi. Now, to have a diagnosis of chronic bronchitis, you have to have an infection, bronchitis, active mucus-producing bronchitis, roughly half of the year to get you a diagnosis of. So if you only have it for 3 months, it's sort of just bronchitis with a nasty component to it. But that's a relative term. These people never are usually totally free of bronchitis. They're always sputum producing when they're coughing. History then, frequent respiratory infections. They always get respiratory infections. They have a productive cough. It doesn't have to be purulent, but it's usually a colored mucus, usually greeny, yellowy. Physical exam, they're often overweight versus pure emphysemas that are skinny and barrel-chested, skinny arms, skinny legs. They have rhonchi. What's a rhonchus? Sounds like a Ford vehicle. A rhonchus is a noisy, wet, giant row. So it means bronchial wetness. So when you pass air through it, it makes a lot of noise. This is the stuff you hear when you walk in, and you can hear it across the room without your stethoscope. Big, wet stuff. Rowels or crackles are little, fine noises. Alveoli popping open with water going through it. So, yeah, water through a straw. That's good. We've got chronic bronchitis here. They generally will have jugular vein distension because they have increase in intrathoracic pressure. They may or may not have, they probably won't have cor pulmonale from chronic bronchitis, but they will have increased intracranial pressure from hyperexpansion of alveoli and difficulty breathing out. Increased air retention, if you will. Often have pedal edema, hepatic congestion if they have right heart failure. Yeah. Your orders are pretty straightforward for COPD, whether it's bronchitis or emphysema. Patient achieves position of comfort. They will often sit in a tripod position. When you get there, they're in a tripoding because that's their position. Or you can transport them in a semi-Fowler, semi-sitting up. They breathe better that way. They have a little bit more control. I was reading a case from Skamania County where the patient was sat up for like 3 nights sitting on a stool until it didn't have a back. So it's difficult to sleep sitting up without having a back to the stool. So he went out in his pickup truck because he could then sit up. He didn't do well, by the way. Oxygen by nasal cannula if they're cyanotic, if you think they have respiratory distress, if their O2 sat is low. Consider, if they're in respiratory distress, of whichever thing, consider CPAP as your first line. Intubate, RSI, lidocaine is okay in the intubation of chronic obstructive people and asthma because it decreases bronchial, the cough reflex. So that should increase, that should make it easier to ventilate the patient. It basically numbs the mucosa. I used to give patients med-nebs of lidocaine when they were in paroxysmal coughing episodes. That is not in your orders, but I'm just telling you that lidocaine is good to, because there's a few downsides of it that you have to be aware of. We can maybe go to that someday. IV, EKGs, because dysrhythms are common in COPD, but don't get too excited about them. It's very common to have bigeminal and trigeminal rhythms in COPD. If the patient's having cardiac symptoms, yeah, then get excited about that. Albuterol, 2.5 milligrams in 3 cc's with Atrovent by a med-neb inhaler. Whether they're wheezing or not still works for emphysema, improves emphysema and COPD, improves the bronchial dilatation, improves airflow. You can repeat that. Solumedrol 125, there's always an inflammatory component. So the Solumedrol, even if you think, oh, what if this is an infection, pneumonia? You're not going to hurt them with a single dose of steroids. If they have pneumonia on top of it, they need antibiotics. A single dose of steroids is still going to decrease inflammation. It's not going to affect the ability of the antibiotic to work or not work. Capnography. Now, capnography you can use your normal EtCO2, obviously between 35 and 45. It may be higher in a COPD patient if they are CO2 retainers. It may be 50, 55. If the patient is mentating normally at that point, it's probably okay, and you can watch it. You probably won't be able to decrease that much. It also allows you, when you're monitoring the patient, if you're giving them high flow O2, the downside of high flow O2 on a COPD patient is that they may be no longer working on a CO2 respiratory drive. They may be on the hypoxic drive because their brain has shut off their response to CO2. So if you put the capnography on them while you're monitoring, if their CO2 starts rising while you're treating them, it's probably indicating that they're hypoventilating in response to the oxygen. And then all you need to do is coach them for breathing, or breathe for them, or decrease your oxygen saturation a little bit, your oxygen concentration. Now, only about 10%, it turns out, we used to think it was higher, but only about 10% of persons turn out to be CO2 retainers. So it's not as big a deal as we used to think. So if you're a gambler, 1 out of 10 isn't bad, right? Asthma, chronic inflammatory disorder, results in widespread but variable airflow obstruction, which predisposes to wheezes. Wheezes are airflow through narrowing and changing bronchioles. And it's the characteristic of asthma. Asthma can be triggered because the airway has become hyper-responsive and is triggered by, and it can be triggered by a number of things, which could be an allergic a substance to which the patient's allergic, can be triggered by emotional stress, it can be triggered by exposure simply to changes in humidity, changes in smoke content, particulates. Whatever the cause, the underlying thing is a release of histamine, which causes bronchoconstriction and bronchial edema. After that if that continues on for about 6 to 8 hours, a trigger substance causing the histamine release and other substances, then immune system cells invade the bronchial mucosa and start producing other substances, including histamine, which cause more and more edema. So you get an additional, you get after the attack is going, if you don't break the attack, then the attack gets worse if you don't treat within that 6 to 8 hour period. So the net effect is you end up with extreme areas of extreme bronchial constriction, which decreases the amount of air flowing into the alveoli. You get increased mucus production as well, predisposing to infections, predisposing to obstruction of alveoli. Asthma, identify the immediate threats. So 1 to 2 word dyspnea characteristic, decreased breath tones, or absent wheezes. A real asthmatic should have wheezes. If they don't have wheezes, it means they're not moving air. Tachycardia, decreased oxygen saturation. When you start out with asthma, the first thing you hear are expiratory wheezes. Then you get inspiratory and expiratory wheezes. Then you lose wheezes as it becomes more obstructed. So, history, and then the important things in your history, besides your standard sample, is history of asthma-related hospitalizations. If they've been hospitalized this year and they're not having another attack, you can their chance of being hospitalized again from that attack, from this current attack, is about 1 in 2. So it's about 50%. So that's where the money. If they have a history of being on a respirator or ventilator for asthma, consider any attack as a significant attack, because if you've been on a ventilator once, you're going to be on a ventilator again. Physical exam, dyspnea, wheezing, cough, but of course the wheezing isn't present all the time, so couple word sentences, one word sentence without wheezing is bad. Look for hyperinflation of the chest, because they're not exhaling again. The problem is breathing out as much, and an accessory muscle use. Auscultate breath sounds. Measure peak expiratory flow. And you say, well, we don't carry those things. Yeah, but any asthmatic who's being taken care of by a reasonable physician will have a peak expiratory flow meter. And they know where it should be set. They know what they should be able to do. Have them blow into their own thing and see. If they're meeting their goal, they're probably not super bad. If they're down to 20% of their goal, then they really have significant obstruction, and they need to be aggressively treated. Your capnography in asthma, you could use your capnography as a cheap peak expiratory flow meter, because capnography in asthma is characteristically the slow expiratory phase tapering off so that you have the so-called shark fin versus the nice rapid expiratory phase. And it's this upslope that their peak flow meter is testing. It's how well they can breathe out. And that you can see on your own. You can have them have them test this with your capnography. It's a cheap way of doing that. Treatment goals of asthma attack is correct hypoxia, reverse bronchospasm, reduce inflammation while maintaining the airway and supporting breathing. So, your protocol: allow patient to achieve position of comfort. If they're comatose, that's easy. Administer O2 high flow mask, IV, and albuterol and Atrovent. Now, CPAP. You can try CPAP, and we do CPAP with the albuterol Atrovent. If they can't tolerate the CPAP, deliver it. If they can't tolerate CPAP and they're getting worse, you need to intubate them. Now, they need Solumedrol. We want to treat that inflammatory response, not the one that's right there that minute, because your Solumedrol doesn't work instantly. It works maybe 2 hours later, maybe 3 hours later, but we're planning on this patient doing well, so we want to make them better. We have, if the patient continues, they're not responding to your albuterol, we will add magnesium, mag sulfate, 2 grams delivered over 4 to 5 minutes for the adult. We have had some really good, at least anecdotally, some really good results from that here. CPAP I mentioned. Intubate, if the patient needs it, you need to intubate. RSI with lidocaine to decrease the paroxysmal portion of the inflammation. And I would recommend ketamine as your sedative during the RSI. Ketamine has the curious ability to make people breathe better, makes ventilation easier. We we are exploring won't happen tomorrow, won't happen probably, but we're exploring having you use low-dose ketamine to assist in CPAP as well. Low-dose, not sedative level ketamine. But we're looking at that and seeing what the science looks like. Now, a child in status asthmaticus, you can't ventilate the patient, you're having a difficult time just with your med-nebs, and the patient is in pure status asthmaticus, then we will add epinephrine to it. And epinephrine, I would prefer, of course, IV drip at about 0.1 micrograms per kilo per minute. If you don't have an IV in, which I would certainly hope you would at that point, or an IO, they could also have 0.1 milligrams or 0.1 cc's per kilo per IM. I would much prefer the epinephrine IV. You can control it. Now I have a whole bunch of stars down there with the adult, for the adult. I think it works well in adults too. And IV epinephrine it can be nicely controlled. And if you had an asthmatic in status asthmaticus, an adult, I would have you call in and say, I want to use epinephrine, an IV drip on this patient. And then if you're really in trouble with a patient, you don't have the time to call, do it and tell me afterwards. I don't want somebody dying of status asthmaticus because we're too cautious about using medication that we know that works. I used to use IV epinephrine all the time, even before we had developed it so nicely to be done as a drip. We used to use, 0.3 milligram IV push, which was kind of that has a little cardiac effect. This is good. Now, what is status asthmaticus? A severe prolonged attack that cannot be broken by bronchodilators. Okay? And it leads to imminent respiratory arrest. So that needs to be aggressively managed with airway, ventilation, transport immediately. So. Couple things on really other, I'm going to bing through these ones pretty fast. Upper respiratory infections, frequent patient complaint. They don't generally call you for most URIs, so I'll talk about the ones that they might call you. They're rarely life-threatening, mostly caused by viral and bacterial infections, and any part of the upper airway can be affected in a URI. Typically resolve without treatment after several days of symptoms. So, upper respiratory infection includes rhinorrhea and rhinitis, just nasal congestion, nasal secretions. Generally speaking, they can also be allergic in origin. Pharyngitis, sore throat, pain on swallowing. The worst sore throats usually come from mononucleosis. The next ones come from other viruses. And then strep throat, which is curiously not it's not life-threatening as strep. Strep throat goes away after a few days, sometimes associated with fever, sore throat. The reason we treat strep throats is because of the autoimmune problem that happens in response to the strep bacteria if it's not treated. Some persons will develop rheumatic heart disease, which is basically an autoimmune phenomena. Some person will develop acute glomerulonephritis, renal failure on the basis of autoimmune response. The only reason to treat a strep throat is to stop these things. It's treated by penicillin or erythromycin. Middle ear infections, otitis media, we don't treat children with otitis media now. we hardly treat that anymore unless the kid has a fever or is toxic. Most of the time, it goes away without antibiotic treatment. Since we've developed the HIV, the Haemophilus influenza bacteria immunization, children don't get otitis media from Haemophilus influenza, and then they don't get meningitis from Haemophilus influenza, which was the #1 cause of childhood meningitis when I went to school, and actually probably still when Marty went to school. That's almost disappeared now with the immunization. Laryngitis, most laryngitis is viral. It's going to go away. Difficulty swallowing, drooling, excessive salivation, extreme pain in the laryngeal area, maybe epiglottitis. Epiglottitis doesn't hardly occur in children anymore because that also was caused by Haemophilus bacteria. Now they're immunized, they don't get it. This is a picture of epiglottitis. Adults get it now, and it's generally from a staph, really, older children, adult kids, people that haven't been immunized. And it's a little bit easier to manage in adults. If a patient does have epiglottitis, we try to treat it symptomatically, and it does respond a little bit to racemic epinephrine temporizingly. In some cases, it's always worth trying it, and then we set them up. If they really have epiglottitis, you set them up in what we call a double procedure. We attempt to intubate in an operating room setting so that we can, if we can't intubate the patient, we go ahead and do a crike or a tracheostomy. So basically, management of upper respiratory infections is maintaining the airway and getting them for evaluation if you actually have a problem. Now, pertussis. Got to talk a little bit about pertussis. It's whooping cough. It's an extremely contagious disease caused by a bacteria called Bordetella pertussis, and it's spread in droplets, airborne droplets, just like everything else. Almost all your viruses, almost all your things are airborne droplets. The airborne droplets either directly contaminate you when they cough at you, or they directly contaminate you when your kid has it and you kiss them, or you kiss the kid and you had it. Or when the droplets get on a surface, you get it on your ungloved hand, and sooner or later your ungloved hand gets in your nose and your mouth and your ears and every other orifice that you own, because that's what human beings do. So how do you stop you stop the droplets. You have barriers. Mask barrier for the patient, a mask barrier for you. You have gloves. You take your gloves off and you wash your hands. You don't lick the patient when you're transporting them. Okay. Symptom onset from exposure is 5 to 10 days, although some people allegedly go as long as 3 weeks. Usually bacteria things are a 5 to 10 day incubation. It starts out as a simple upper respiratory infection. Runny nose, weepy eyes, upper congestion, a little sneezing, coughing, and the symptoms progress to fits of paroxysmal coughing. Now, the catarrhal phase, the runny nose, snotty nose phase of the sneezing is usually 1 to 2 weeks, like a common. So you think you got a cold. A cold normally goes away within about 10 days. So 1 to 2 weeks of this, and then you start having paroxysms of cough. Uncontrolled. You have so much irritation. You cough, 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 as a paroxysm, and then you inspire deeply, and that's where the whoop comes from. So cough, 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 cough on the inhale. That's whooping cough. Now, that can go on for as long as 7 to 8 weeks more. At severe coughing. During both of those phases, you are contagious to other people. Now, who gets in trouble from paroxysmal coughing? Young people, kids. This used to be one of the #1 killers of children. Infants. Infants cannot maintain that paroxysmal cough. Old people. Younger people break ribs in these paroxysms. It's so severe. And you can also pass out, you have syncopal episode after that prolonged kind of coughing. So this is really dangerous to kids, and it's totally stopped. It's becoming more common now because people are taking sabbaticals from having their children immunized, which is both a personal and a societal sin in my book, but that's another story. And of course, it's nice to think of it as a sin because some people refer to religious reasons for not having immunizations. It's true. You could sacrifice your children. They used to do that in the Bible. You know, just don't sacrifice my children. You know, that's the difference. Well, if it's a child with it, we would first of all if a child is sick enough to be admitted with this, they would need to be probably in a pediatric intensive unit. So they would ultimately be transported to Randall from either place. You know, Legacy is not admitting any critical children anymore either. So. No, antibiotics. Erythromycin used to be the drug of choice. I think probably now we use azithromycin, which is more tolerable on your stomach, among other things. But if the point is, this is something you can get if exposed to. We've had a couple of nurses who got it from persons they admitted at triage. And then, you know, four weeks later, as they're coughing and looking terrible, we say, "How long have you had this cough?" So, treatment: prevent exposure, oxygen, beta agonists may help, especially if they're having wheezing and stuff. We might be able to slow down their coughing a little bit by we would give them some inhaled, maybe a little lidocaine, might stop their coughing. And if they have apneic periods, obviously they have to be ventilated. It just doesn't go away. Once you get it, and the reason the immunizations work is if you survive if you get pertussis. My mom had pertussis when she was a baby because they didn't have immunizations when she was a baby, and she could never get it again because she develops a natural immunity to it by getting the disease. So what we do with the immunization is give you the killed bacterial toxin. You build up an immunity, which is only a partial immunity, and that you have to get boosted now and again. But it's a way of avoiding it. If most natural infection, if you get the infection, you get natural immunity. All right, let's take a break for just about 10 minutes, okay? Somewhere here is a thing that says shutter. Oh, there it is.
I usually always go for the red button.
Yeah. I believe that just goes, well, heck, I'll just leave. Okay. As we get started, I need to confess an error that I made. It's not a fatal error, but I always forget. I mean, people have said we have liberal protocols here, and by God, we actually do, because I forgot we did include on the last iteration. We do allow you to use either Versed or ketamine for mild sedation to assist in CPAP. The dose of the ketamine for CPAP is 0.5 milligram per kilo for mild sedation. So that's not a real sedative level. It's just a mellowing out and I'll breathe better level. So it is in the protocol, and somebody brought it up, someone who's studying protocols. So it's came up. Well, I mean, what do I know what's even in there? Okay. Yeah, I mean, he didn't even remember either. Okay. Pneumonia, not much to say about pneumonia. The patients may present with with respiratory distress, but even pneumonia you can try, if they have respiratory distress, try CPAP. It does help pneumonia sometimes. If the patients don't get better with CPAP, then you stop it and you do other things. Most pneumonia, either bacterial or viral infection. We have now community-acquired pneumonia is the kind of thing you get just from being around pneumococcal disease mostly, and atypical pneumonias. And then hospital-acquired pneumonias come from bacteria that have been your exposure to bacteria in the hospital is more dangerous because we've created antibiotic-resistant forms of bacteria. So if you get a staph, even if you get a strep pneumonia, strep pneumonia is now resistant to, about 40% is resistant to penicillins and to penicillin-like drugs. So we need to treat with two different drugs. Problem with pneumonia is alveoli may collapse. You may get consolidation of whole lobes, and you get a ventilation and a ventilation perfusion disorder. Don't forget aspiration. Old people or nursing homes are at risk for aspiration pneumonia. It's not at all uncommon. It's probably the second most common cause of sepsis in nursing home patients, most common being urinary tract sepsis. Pneumonia, patients with pneumonia, dyspnea, respiratory distress will tell recent fever, chills, weakness, malaise, cough, often associated, painful, often productive of sputum, tachypnea, tachycardia related to the, often to the fever, crackles in the affected lung. The basis of the RALs are present in lobar pneumonia and pneumonias. Bronchi are also often present in pneumonias. And there's just decreased air movement to the affected lungs, so the patient has respiratory distress. Maintain the airways, support breathing, high flow, oxygen, CPAP trial, vital signs, IV fluid. Avoid fluid overload in pneumonia. Now, sometimes it's difficult to determine, particularly if they do or don't have, if they don't have a fever, you may be confusing pneumonia with congestive heart failure. Both have crackles. If you gave someone in congestive heart failure high or a lot of fluids, you get them fluid overload. If you give somebody who has pneumonia Lasix, for example, you dehydrate them, which makes it worse. So it's a fun IV access, but avoid too much fluid and avoid things that would make a patient fluid short. We're going to treat with antibiotics, beta agonists. If it wheezes, treat it with wheeze medicine. It helps. Lung cancers, the main problem with lung cancer ultimately is disruption of diffusion. So they may have, and they may also have obstruction of bronchial segments due to the infiltration of the cancer. The majority of cancers caused by carcinogens secondary to cigarette smoking or occupational exposure. Sometimes a lung cancer starts somewhere else and metastasizes, particularly true of things like ovarian cancers. Chief complaint that they're going to call you for is respiratory distress. This may be an end-stage kind of problem for them then. They now have significant ventilation or obstruction, ventilation issues or obstruction, and significant diffusion, so there'd be hypoxic CO2 retaining perhaps. Or they're going to cause you, people call when they see blood. So when they disrupt the bronchus, get a little bronchial tear or a little arterial bleed, and cough up some, and they start having hemoptysis. They get very scared by that. That's what they call for. You're not going to be able to treat that per se, but you treat this. You can treat the anxiety, treat the symptoms, treat the hypoxia that you find. Adenocarcinoma is the typical cancer of the lung, which comes from smoking. But there are other ones, small cell carcinomas, epidermoids, large cell carcinomas that are not related to carcinogens. You just get them. I mean, unfortunately, I've had a couple of friends who had small cell carcinomas, which they'd never smoked in their life, and they'd never been around people that smoked. It just happens, you know. Sometimes the magic doesn't work. Assessing a focus history, you can focus on their symptoms at the time, previous cancer-related treatments, hospitalizations, whether they've ever had hemoptysis before, evaluate for severe respiratory distress, and then it's just general principles of your managing. If they're severely short of breath, you can certainly try CPAP. Toxic inhalations. Okay, you can inhale heated air, chemical irritants of any sort, and steam. And you get airway obstruction due to edema and laryngospasm due to thermal and chemical burns, and you can get lower alveolar damage as well. In your focused history, you need to determine the nature of the substance, length of exposure, loss of consciousness. Because people with loss of consciousness cannot protect their airway at all. Also, protect yourself. So the most important thing is get the hazmat people there to get people out of the noxious substance, or have fire remove them from the burning building before you are attempting to evaluate them. Marybridge and OHSU can be contacted for any questions you have immediately about toxic chemicals, but most of the time you don't need to know anything other than where the patient was and what they could potentially have been exposed to. So assist ventilation is needed, 100% O2, intubate as needed, CPAP you could trial if they were dyspneic to start with. IVs, albuterol for wheezing, if you have wheezing present. Now, specific treatments. You have chlorine dust or gas exposure, so it's an industrial exposure. Humidified 100% O2, pulmonary edema, and bronchospasm is treated as if you would normally treat bronchospasm. So wheeze medicine for the bronchospasm. It won't hurt to try corticosteroids. You're dealing with an inflammatory issue. CPAP, positive pressure breathing. Cyanide inhalation. Okay, cyanide is probably overrated in our exposure. At least the burn center over in Portland is pretty anti-treatment for cyanide poisoning because of a couple of reasons we'll get to, but they don't find that there's really a lot of particularly closed space fires. They really don't have that much cyanide exposure. Generally speaking, if you find somebody who's comatose, apneic, pulseless in a closed house fire, it's not cyanide poisoning, it's lack of oxygen and carbon monoxide. Typical signs of cyanide poisoning would be altered mental status, seizures, and then coma, tachypnea, apnea, even though they have apparently an adequate oxygenation when you get oxygen on them. Shock, some vomiting. Now, if you walk into a industry and they happen to be using cyanide gases or cyanide salts, well, then you have an idea there might be cyanide present. In a closed house fire, when you burn plastics, you get cyanide as well. So things that have plastics or things that have, and it seems to be popular in fires from mobile homes because of the foam insulation that they use. We have changed our cyanide treatment approach, only that we've given up the cyano kits, which are now up to about $1,200 a pop and outdate every year. Like I say, the burn center hates them because once you use the cyano kit, you can't use the pulse oximeter on the patient for it's inaccurate for up to 2 to 3 weeks, which kind of limits their ability to follow your respiratory needs. And not everybody wants an art line to get a true arterial PO2. So we've gone back to the old-fashioned way of using sodium thiosulfate. If you think you have an exposure possible, you've taken a person out of a fire, you have the patient still comatose, they've had seizures, they've got a nice, their SpO2 looks like you've got it at 99, and they're ventilating well, you're ventilating them well, you've got 100% oxygen, and they're still have altered mental status, and they still are having these symptoms. Think, well, maybe it's cyanide. You can use the sodium thiosulfate, 25% solution infused over about 10 minutes, 50 cc's. That will not change your SpO2. That will not change your, that will not affect your pulse oximetry. Then they go to the closest hospital if the hospital wants to make the choice of treating with the cyano kit. They can do that. Hydrogen sulfide gases, they use hydrogen sulfides in a lot of grain elevators and things to help kill molds. That causes respiratory depression, so you just assist ventilations. And it can also cause seizures. You treat seizures per protocol for SED. Carbon monoxide, colorless, odorless gas, builds up in confined spaces, mines, autos, poorly ventilated homes, suicide attempts we see as much as anything. And it is, of course, hazardous to firefighters and rescue personnel if you're cleaning up in the fire or after cleaning up in the fire. binds to hemoglobin. It's more powerfully bound than is oxygen, and therefore you get hypoxia at the cellular level. Because of the carboxyhemoglobin, it's carrying the CO rather than oxygen, and doesn't like to give it up. Determine the source and length of exposure. Usual symptoms starts out mild exposure, headache, to the point of headache on to confusion and agitation, ataxia, loss of coordination, loss of consciousness, and seizures. We have the CO, so determine carbon monoxide level in the environment and with a commercial device on the patient. It's like a pulse oximeter, only it reads CO. And you should determine the CO level before administering any antidote to cyanide if you think there's a cyanide thing, but it's not as important with the thiosulfate. But check the CO level. If you suspect CO, you should check that prior to giving the sodium thiosulfate. If they come out with an SpCO2, a pulse oximetry CO level of between 3 and 25%, and they have neurologic symptoms, headache, dizziness, etc., they need to be treated, high flow O2, transported to the ED. 100% O2, even by nasal cannula or by mask, or by CPAP is even better, will reduce your CO level by half within about a half an hour. Matter of fact, if you are a firefighter and after you clean up at a fire, you're supposed to check your CO levels. And if you have a CO level of up to 10%, you should be treated. And the fastest way to do that is just to use a CPAP with 100% O2 for about 30 minutes. That usually resolves symptoms. If your SpCO level is greater than 25%, that patient should be treated in a hyperbaric chamber. Now, sometimes your SpCO level is inaccurate. There's a couple things that make it inaccurate. So not everybody who has if you really have CO level of 25, you should have lots of symptoms. So a person who has no symptoms, and your machine says, oh, they've got a CO level of 30, there's something wrong. That person should be unconscious. That person should be, at the very least, complaining of a severe headache, vomiting, total dizziness, and you just have to. What makes it inaccurate? Sometimes treatment with silly little drugs that we had a patient a couple of years ago, had 2 different levels of positive CO, but she was on pyridium for a urinary tract infection. And it causes a colorimetric change that fooled the colorimetric sensor on the carbon monoxide level. So always treat the patient, don't treat the machine. Pulmonary embolism. Okay. Pulmonary embolism, the emboli could be air, could be a thrombus, could be fat, could be amniotic fluid. The most common thing we see in pulmonary emboli, of course, is a thrombus, and the most common source of pulmonary embolus is from deep veins in the legs, the large veins in the legs that become clotted, and then a thrombus breaks loose, goes up to the lung, gets into the pulmonary artery, and depending on how big it is and how well it plugs up one or more branches of the pulmonary artery. Now, if it gets into small pulmonary arteries, that causes some widespread little defects in the lung. If it's a huge embolus, it can block off a major pulmonary artery, which then stops any blood flow to a large portion of the lung or maybe an entire lobe of the lung. Then you get ventilation and perfusion mismatches. You get lung that's being ventilated, the alveoli, but it doesn't have any perfusion in it, so there's no gas exchange going on at that point, and that totally throws off the blood gas arrangement. The next most common cause of deep vein thrombosis, large vein thrombosis, from the pelvic veins. You can't see those. You can at least feel, if someone's got a swollen, tender leg, you can examine that and say, hey, swollen, tender leg. Or if they're sitting there with a cast on their leg so they're not moving their leg and they end up at risk for pulmonary embolism, if they call in saying, hey, I'm short of breath, I have a little chest pain, I'm short of breath, I'm coughing up a little pinky sputum, and they look at it and you say, well, gee, you ought to have that cast looked at too. Well, that's where the thrombus is, it's in the leg. Things that are risk factors for pulmonary emboli are the risk factors for hypercoagulability, which is recent surgery. Why recent surgery? Because when you're healing from your surgery, you have a lot of intrinsic factors that are trying to make you heal, one of which causes blood to clot quicker. You become hypercoagulable as a protective measure for your body in response to the healing, but it also, some people can clot fast. Long bone fractures, mostly because you immobilize the extremity. Immobilize, your legs get rid of, the blood moves in your veins because of massaging of the muscles, mostly. So when your leg is immobilized, it's not massaging, you're not moving it in there, blood slows down, blood flow slows down, and you clot. Bed rest, same thing. Pregnancy, because it's a hypercoagulable state. And postpartum. Oral contraceptives, because they're mimicking some of the same changes that occur in pregnancy. Tobacco use. Tobacco use causes everything. So, then there's a family history of it. We now test, if you come in with a pulmonary, if you, your wife, somebody comes in with a pulmonary embolus, we test that person for the genetic factors. There's a genetic link for hypercoagulability, and then you should test his or her children to see if they got it too, because they're at risk for things. Then they can adjust their lifestyle to that. If you've had a previous pulmonary embolus, you're always at risk for it. Again, which means you should probably take anticoagulants the rest of your life. Coumadin. So focus history, you've got symptoms, then you focus on what are the possible risk factors to this patient. Sudden onset of dyspnea and pain, cough, often blood tinged. Now, they have signs of right heart failure often. If this is significant pulmonary embolus, they will have acute cor pulmonale. Now, this is different than the chronic one. They haven't had time to develop hypertrophy. That takes months, years to get hypertrophy, but they get dilatation of the right ventricle because it's getting bigger and bigger. It can't pump all the blood forward through that big embolus. So not only will they have a low SpO2, they may have an elevated CO2, and they'll have jugular vein distension and signs of right heart failure. And you may even see it on an EKG. You may see right heart strain. Then examine their legs, see if you've got a potential for a thrombus in the leg vein, if they got a cast on, etc. How do you do this? Maintain an airway, support breathing, high flow O2, maybe intubate them. If they go into a cardiac arrest, routine CPR, high performance CPR, high flow O2, manage the airway, and you should get them to an appropriate facility. What's an appropriate facility? For a PE, an appropriate facility is take them where they have a 24/7 interventional cath lab. Because that will, we will go in, if they have a big pulmonary embolus, and we get them in time, even if they had a cardiac arrest, and you get them there with an ROSC, we'll go in to intervention and pull that clot out. But you need a 24/7 interventional lab. So that would be Peace Health Southwest in this area. Pneumothorax. Spontaneous pneumothorax occurs in the absence of blunt or penetrating trauma. The risk factors are smoking and family history. What they do is they get little blebs on the little weak spots between the alveoli, and they get a bleb alveolus that didn't perfectly form and is now right up against the visceral pleura, and it's thin walled, and it can spontaneously rupture. Doesn't cause any significant bleeding or anything, but the air leaks out into the thorax. A spontaneous pneumothorax is painful. The symptoms are sharp pleuritic chest pain, often shoulder pain, particularly if it's a lower bleb near the diaphragm. Often preceded by coughing or lifting maneuvers. Almost, this is not a traumatic. This is not a traumatic one. So it's not, someone who falls and gets a pneumothorax is another thing. A basic rule for me is that nobody ever died of a simple pneumothorax. It's uncomfortable. They have shortness of breath. Now, if it's that's probably the deal. Thank you. Okay. There's a few CNS dysfunctions that can affect everything from traumatic brain injury, tumors, CNS drugs that can affect their respirations. And the most common one that we know is narcotic drug overdose. And so we always evaluate for that, and your treatment for narcotic overdose with respiratory depression is very straightforward. 2 milligrams of Narcan, and you can give that IV or give it theoretically IM, although it's poorly absorbed, or intranasal, which is rapidly absorbed. Treatment of CNS dysfunction is outside of CNS dysfunction from narcotics is maintaining airway, supporting breathing, and treating any underlying cause that you're aware of. Spinal cord, peripheral nervous system problems that can affect respirations are trauma, polio, myasthenia gravis, other viral infections, tumors, traumatic injury, and your management of that sort of thing is maintain airway, support breathing, cervical spine precautions if we're dealing with a potential trauma. A couple words about capnography. In-tidal CO2 monitoring refers to non-invasive measurement of exhaled CO2. Invasive measurement would be to take an arterial sample and do your CO2 like we do when we do a blood gas. This is non-invasive. A capnograph is a calibrated visual waveform. Capnography gives you instantaneous information about metabolism. It shows you whether CO2 is being produced. Perfusion, how well it's being transported. And ventilation, how effectively it's being eliminated. Now, your typical waveform, the section here, A to B, is the exhalation of CO-free gas from the alveolar dead space. B to C is dead space and alveolar gases rapidly rising. Then this is your exhalation phase all the way out to here. That's the full exhalation phase. So C to D. And then there's the inhalation phase where you drop down to your baseline. In cardiac arrest, doing capnography can measure the quality of CO2. Now, in this fashion. CPR can be monitored using ET CO2 levels during compression. We know it appears that the greatest chance for you to get ROSC happens when your CO2 levels are greater than 20 millimeters mercury during that cardiac arrest. When you get return to spontaneous circulation, that often shoots from 20, 24, 25, 26 up to normal CO2 levels, meaning you've got return of spontaneous circulation and adequate ventilation and perfusion of the lung. CO2 levels less than 20 could mean you're doing inadequate chest compressions, that your CPR could improve. So we're trying to get the level above 20 if possible. When it's persistently low, less than 10 millimeters, return of circulation is highly unlikely. Marv Wayne's study showed that if it was less than 9 consistently, you had no one return at that point. So that was actually a level that you could say, okay, it's been at 9 for 20 minutes, we don't have a viable patient. That means despite adequate compressions, you're not having any metabolism to produce CO2. So, EtCO2 levels less than 10, 9 or less, measured 20 minutes after the start of ACLS, accurately predicts death, and you can call the code on that basis. Now, with the caveat that even when you start low, when you start in the 12, 14, there have been some cases where we've had ROSC, because it's improved as you've done good CPR and then it's come back. Now, if you have a waveform with all those phases, a full waveform, not just something that goes like this, a little blip. If you have a full waveform with all those phases, that indicates your ET tube is through the vocal cords. And I want you to start making sure that that gets recorded, and then that is downloaded into your chart. So you have to get it on where you can record, not only see it, but record it so that we have that record. I also want you to put down in your narrative that you did these things, that you saw that you had a good waveform, a good number, and everything. But unless we get it recorded, we then, that's one more piece of information that we can say, hey, yes, we had a good waveform. A flatline waveform indicates esophageal placement or could be prolonged death, so there's no CO2 coming out. Tracheal placement with inadequate pulmonary blood flow, as you might get from a pulmonary embolus, or complete obstruction of the ET tube or distal airway. You can also use it on all of our other adjunctive things like an eye gel. It works great on the eye gels too. An intubated patient, you monitor it constantly during transport, and I want it recorded and documented every time that patient moves on a gurney. Moves onto your gurney, moves off your gurney, and then we document that we have, because you can immediately tell if it's been disrupted, if it's been displaced. Now, you can get a good EtCO2 level with right bronchial or placement. So if you go down to if you put your tube in too far, go down to the carina and slide down the right main stem, you still will get CO2, which means you've got a good ET tube, but you still have to monitor the patient, make sure they have breath tones on both sides, and it's working well. You may have a falling PaO2 at that point. So this doesn't guarantee you that you wouldn't have a right main stem placement, but you will have a good ET. If you get a right main stem placement, you probably won't dislodge that tube when you move them from a gurney to a gurney. Now, you monitor EtCO2 levels. In patients with increased intracranial pressure, we are recommending that you keep them low level of what is called eucapnia. In other words, keep them around 35. That's the level we aim for. Not too low and certainly not high. Capnography will show the hypoxic drive in CO2 retainers. This little thing says only 5% of COPDers have a hypoxic drive, maybe 10%. So you can follow hypoventilation, because if their CO2 starts to rise, they're hypoventilating. With mild asthma, as the patient hyperventilates, their CO2 drops. as this asthma worsens, the CO2 rises. So it's a way to follow your asthmatic patient, whether they're responding to your treatment. CO2 rising is close to dangerous levels. If it gets above 55, you probably should go ahead and intubate and manage that patient's ventilation well. So, all right, a quick ALPS refresher. Our ALPS cases, we're now predicting that we're well over 2,000 cases admitted into the ALPS study nationwide and internationally, Canada, and we're predicting that we'll probably have the full thing done as of November of this year. That will be done at that point. Now, how long it takes them to analyze the data is going to be another thing. So what the results of that are, but it appears that there's been no major difference between any of the arms, either amiodarone or lidocaine or placebo, saline, because they haven't stopped the study. They've broken the code, and the smart guys have looked at it a couple times now, and they have not suggested that we drop one or the other out of the study. They say, oh, you need to keep getting more information. So we'll see how it goes. But remember, ALPS, amiodarone, lidocaine, placebo study, non-traumatic out-of-hospital cardiac arrest. You have to have vascular access, persistent recurring VFib, VTAC after one or more shocks, which means in definition that you will not give the ALPS kit until you've done 2 shocks. 1 or more means 2. That's how to interpret that. We won't even get it. So you don't give it after the first shock because you don't know whether the patient's going to be in VFib at the end of 2 minutes of the next 2 minutes of CPR. At the end of that next 2 minutes of CPR, you analyze. If they are in VFib, the first thing you do is shock. So you always have to have given 2 shocks before you give any of the ALPS drugs. Okay? Definition. Now, you can't use open label IV amiodarone, known hypersensitivity or allergy to amiodarone, protected populations. That's all of our studies. What counts as a shock? Any shock administered by ROC agency, first responder BLS, bystander AED shocks, non-ROC agencies, any shock, because the AEDs don't tell you to shock anything except VFib or pulsus VTAC. So any shock given counts as the first shock. If a second AED shock was given by a layperson, that would also count as the second shock. Your internal cardiac defibrillators don't count as shocks because we can't monitor them. You have to be able to interrogate them. They do funny things sometimes. So persistent recurring VFib, confirmed VFib, pulsus VTAC. If you are at the point where you think they need an antiarrhythmic drug, that's when you give the ALPS drug. We didn't give in our old protocol when we were using amiodarone, we didn't give the amiodarone after the first shock. We didn't give it until well after the second shock usually. So when you're thinking a drug, that's when we use the ROG drugs. Needs to be given as soon as possible, and we're doing very well, by the way, within 10 minutes or less. You can give it at the same time you give the epinephrine. If VFib, VTAC returns, you do the full ALPS protocol, which is going to be syringes 1A and 1B for the first dose, and then syringe 2 for the next dose. If you had circulation, if you had a non-VFib after the first dose of drugs and the next shock, then you don't, but then it comes back later, it recurs as VFib, you give that second dose then. So 2 syringes the first dose, second syringe, there's just 1 syringe in the second dose, except for really tiny people. So if you have little itty bitty people, we use 1 dose each. If VFib recurs after you've given all the drugs, you can use magnesium, repeat epinephrines, repeat shocks, but no open-labeled amiodarone or lidocaine. You got to use the ClearLink adapter because it doesn't work without it. Put the ClearLink on first, then attach the syringe. Call this number. It's written on the kits. As soon as you're able to say that we've enrolled the patient, because the ROC agency has to notify the patients they were enrolled, has to let them know that they have the option of being in or being out of the study. That doesn't mean your data is going to be thrown away, because we get their data up to the point they say, no, I don't want to be in the study. We've only had one person I know of in Clark County withdrew from the study after they were resuscitated. Bizarrely enough, but document what you normally do in a cardiac arrest. You need to upload the CPR process file, the PCO file, from your monitor so that we can analyze that. Just follow your agency's requirements for that. Okay. We have a couple of things now. I guess we get to Marty and Marlo. Who gets to go first? Marty or Marlo? Yeah. Well, this is Marty Bell right here. I do.
Okay, everybody ready? Ready to get done? So these were a couple of cases that we brought forward because they were interesting, challenging cases that came up recently. This was Vancouver fire reports that I reviewed and cases that came to Southwest. This was both of them were traumas, I guess. This was a MVC, single car accident. AMR was on the scene when Vancouver Fire arrived to find this poor guy in the front seat of a small compact car. Apparently the vehicle struck a light pole at high speed, had major intrusion. He was wearing a seatbelt, the airbag was deployed, and the patient was unconscious but breathing, although inadequately from the description. His pulse ox on the first recording was 68%, so profoundly hypoxic. Full spinal precautions were employed because of the mechanism. He was placed on oxygen at 15 liters non-rebreather, and vascular access was obtained. I'm not sure if this was distal tibia or proximal tibia, but anyway, IO was obtained initially, and then subsequently an IV was inserted. Patient had profound depression of his level of consciousness with a Glasgow rated at 3. He did have vitals, though. He had a pulse at 70 and blood pressure initially of 140/76. His respiratory rate was compromised with a respiratory rate of 10, probably related to his altered mental status. And he was noted to be in a sinus tach with no obvious elevation or depression of ST segments. There you can see that he had an IV inserted in addition to the IO, and IV fluids were initiated. His glucose level was 105. Because of his respiratory compromise, it was felt like he was in need of intubation. RSI was performed with etomidate and sucks, and it was looked like his initial CO2 in tidal was 11. That improved with ventilation. It took 2 attempts, it looks like, on the report there. So challenging. Was anybody in the room here involved in this case, by recollection? So a challenging intubation, but successful with a confirmation of tube placement after the second attempt. Vitals remained relatively stable. CO2 level went from 11 to 24. So I had reviewed this. Unfortunately, this patient expired in the ED, and his pulse was lost shortly after arrival. CPR was started immediately, although this was technically a blunt trauma arrest. A FAST exam. FAST exam is basically our focused assessment with sonography and in trauma evaluation. So we take an ultrasound probe and look initially at the heart to see if there's any evidence of cardiac activity initially, and also tamponade that would be a cause of the arrest. And then we look in the abdomen to see if there's any evidence of exsanguination internally, any free fluid that would be consistent with hemorrhage. And there really was none. In this case, there was no evidence of pericardial tamponade or fluid in the pericardium. There was very minimal cardiac activity. Trauma surgeons and the ED team put bilateral chest tubes in initially, and they had no indication of a tension pneumothorax on insertion of the tubes. A humeral IO was placed as central line placement was difficult. And patient obviously had at the scene an open right foot ankle dislocation as a manifestation of the severity of the impact, as well as the intrusion on the vehicle. They never really got any lab work on this patient, so we don't know if the drug screen was done. Would have revealed anything, but it didn't look like he had any attempt to break, and the team thought that this might indicate a medical cause as the cause of the accident. The EMS2 did a great job in terms of airway management and quick transportation to the hospital as a trauma team patient. So, any questions on that one? Yeah. Yeah, they're the yellow Easy IO needles. Yeah, I had a personal experience recently on one of the transports that came to Southwest with just another case review. Briefly, was a morbidly obese woman that had changed her code status from comfort care to resuscitate me, please. And she was in shock when she got there, and she had no access, basically. So we did put a humeral IO, and it worked really well to put 4 liters of crystalloid into her, get her pressure, central pressures up, and then she drifted down again. So I ended up putting in a triple lumen when we admitted her to give her pressors and everything else that we normally give in somebody in septic shock. So it is relatively easy procedure as long as you remember the positioning of the arm and then your landmarks. So it's a pretty good way to get central access and or give initial fluids and medications. So this is case number 2. This is a interesting guy that sounded like he was quite a character. He was a 63-year-old guy that his wife called and said he had fell the previous night but wouldn't let her call on the night. She found him on his hands and knees. He was conscious but unable to really move his left arm, and his right arm was weak, and he had some weakness in both legs, which are red flags for a spinal cord injury. His past medical history was significant for a ruptured C7 with no neurologic sequela, but he had some persistent pain, I guess, in the area of his rupture. He denied any back pain, but had neck tenderness and pain, and for some reason his spine looked like it was abnormal in its appearance. Most of his discomfort was shooting pain into his left arm. He was found lying supine on the floor with 2 pillows under his head, conscious and alert. He was actually moving his neck and torso around, at a large avulsion laceration on his forehead, which is a harbinger of potential spinal injury as well. He was morbidly obese. I forgot to put that here on the initial intro, but he was a very difficult patient to deal with just in terms of his size and extricating him from the scene. He had severe weakness in his left arm and both leg. About 140 kilos by estimation. And so a C-collar it was difficult to place. His C-spine was manually stabilized, and there was some time that was required to get enough manpower to move him out of his second floor downstairs safely and to secure him and transport him. IV was established, given some pain meds and antiemetics, and transport as a trauma entry. So in the hospital, he had findings consistent with a central cord syndrome. You remember the cord syndromes that you can get with trauma. This is a central cord syndrome where you classically get more weakness in the upper extremities than the lower extremities. And it was not due to a fracture or dislocation, but because of his underlying degenerative disease and spinal stenosis, he had some cord compression at C5-6, which kind of corresponded to the level of his physical findings. He had surgery that day to stabilize and decompress the area, and was discharged to inpatient rehab, where he went pretty extensive and intensive OT and PT with good results, but still had some residual weakness at the time. EMS did a great job. The entire team did a great job in coordinating his extrication and movement safely to transport him. So this can often be, as you know, you're on the front lines dealing with some of these morbidly obese patients, and can be quite difficult, especially with the location where they present. The last thing that I wanted to present and mention to you is that we are actually on the 20th of this month going to change our process in evaluating code 3 stroke calls coming in, and we ask for your indulgence in this effort. We're trying to kind of shake up our process so that we can make some improvement. Our goal is to get patients, 60% of the patients that qualify for IV thrombolytics treated within a 60-minute time interval. And we've looked at our model, and this came up as a thing that may significantly impact the time that we can give, interval in which we can give IV thrombolytics successfully. And for you, it means basically that what we'd like to do is keep the patient on the gurney and take them directly to CT. And that would involve meeting you in the hallway or in the room and quickly determining if the patient is what we call a neuro 911 or candidate appropriate candidate for thrombolytics. That will involve having the ED doc do a quick evaluation, 1 to 2 minute evaluation to determine if these are candidates. We take them directly to CT and have you move them onto the CT gantry, and then be done with your business there. We would commit to not delaying your return to service in any significant way by trying to get a patient in again or doing unnecessary diagnostics. It would basically be just determining quickly whether they're a candidate, taking them to CT, and dropping them off. You're going to take them directly to CT. Yeah. So it'd be a quick evaluation in the hallway or in the room, keep them on the gurney, transport them to CT, and then you'd be done. We will look at this closely and monitor it, especially during the first week and month of the process, to make sure that you are not getting delayed in terms of your return to service time in any significant way. We hope that this will have a significant impact on our ability to provide quicker TPA administration. Yeah. Right. That's it. Well, like I said, I want to hear from you if you have any delays in this process, so we can give immediate feedback to the ED docs and the team. But on a code 3 stroke, we should have a doc there, an ED doc there at the to receive you. Okay. Marla?
patient was clearly in respiratory distress on arrival, tachycardic with diminished breath sounds, wheezing. So the patient was given albuterol and Atrovent. IV was obtained, given Solu-Medrol. It's documented in the narrative. There's an attempt at CPAP. The patient didn't tolerate it well. He was admitted fairly soon after arrival in the emergency department. He was extubated on hospital day 2. He had been trying to make his prescriptions last longer, and so it decompensated. So overall, very good, very appropriate EMS care. As a reminder, this is a patient that can benefit from CPAP. So if the patient is not tolerating it, not working with coaching, remember you have orders for Versed or ketamine to facilitate that, especially in someone with a history of asthma. Ketamine is a good choice because it's got a bronchodilating effect as well. And for, even if this is someone that doesn't need pre-hospital intubation, if they've been well pre-oxygenated with a trial of CPAP, it gives us much more margin for safety. But overall, really good EMS care, and the patient did well. Okay. So this is case number 2. So the crew arrived on scene to find a man carrying the patient who is a very small 20-year-old female with a history of myotonic dystrophy. The man who was carrying the patient said that she'd been vomiting since about 4 in the morning. They had a sat meter at home, and they noticed that her sats were in the 70s, and they tried positioning her. They even had a little home suction. They tried, and they weren't able to keep her sats up, so they called 911. So she was clearly cyanotic when the crew arrived, and it sounds like they just kept that momentum going with the guy walking out of the house, put them straight into the back of the ambulance. So at that point, she was cyanotic. The initial sat that the crew got was 72% on room air. Placed her on a non-rebreather, gave suction, and got ready to intubate. So IO was placed, and so soon after the intubation, the patient went into cardiac arrest. The initial rhythm was ventricular fibrillation. The patient was shocked at 200 joules, and then shocked at 300 joules. Here's the monitor strip. And so they were able to get return to spontaneous circulation. So as we're getting more history, and it sounds like this was both very involved, sometimes in helpful and sometimes in unhelpful ways, family. And this patient had a history of myotonic dystrophy, so had some developmental delay, but also difficulty with muscles of respiration, had frequent aspiration pneumonia. It sounds like for the quality of life, the family had been not strictly following the speech therapy recommendations. So these are the comments that I'd sent in an email, but this is clearly a really difficult case. I was the ER doc receiving this patient, and it was very difficult to oxygenate this patient. We were trying positioning, trying different ventilator maneuvers. The initial chest x-ray showed this left lower lobe pneumonia, and so at the point that I'd written an email on that later that day, the patient died probably 6 hours after being admitted to the hospital, just with hypoxemic respiratory failure. So I do believe that in this case, it seems pretty clear that this patient had a respiratory arrest and then had VFib. You just have to, and in a 20-year-old female, you're very unlikely to have coronary artery disease as the cause. You should always pause before taking someone with a VFib arrest to a non-cath lab capable hospital, but it seems pretty clear that this patient was a respiratory arrest. But unfortunately, we were too far behind the 8 ball when we got to her. I think that the EMS care that this patient got was her only chance. Otherwise, she would have died much sooner. Any questions about this case? No, she died. She died later that day. And there were potentially some other things we could have done. She was a potential candidate for ECMO, but the family ultimately made the decision to transport to comfort care because at that point it's very unlikely that she would even be able to maintain the quality of life that she'd had to that point. But I guess the other point on this case, I mean, this is one of the most difficult situations that you will face as someone who resuscitates people. This is the definition of a crash airway. You've got an airway obstruction, she's hypoxic. So what are some things that you can do to improve your success in a case like this? So positioning, keep the patient upright, let the fluid run down. What else? Say it louder. Passive oxygenation. Yeah, you've got to be doing suction. You can be doing the passive oxygenation at the same time. Any other suggestions? Last thing I'd throw out, so the nasal cannula, if I were faced with a case like this, I personally would grab for a direct laryngoscope and a bougie. You know you're going to be doing a lot of suctioning with the bougie. It makes it really easy to shoot for the area of bubbles. And you want to get this tube as quickly as possible. This is a very, amongst the most difficult intubations that you'll face. Okay. So case number 3, this is from the ambulance crew report. So he was being carried by tarp to the gurney, and so this was a young man with 33 who had been seen at Salmon Creek earlier in the day, had a rib fracture from a bicycle accident. He was given pain medications. He was discharged from the emergency department, and so the initial responding crew was concerned for overdose. He was in sinus tachycardia with agonal respirations, reported about last seen normal about 1 hour ago. And he was transported code 3 to Salmon Creek. So at this point, he had a very weak carotid pulse. They were able to palpate a pulse at 126. There's no blood pressure documented. It was GCS3. He had no response to Narcan. And so he was paralyzed and intubated. Lung sounds clear, good end-tidal CO2. And so this is, so ultimately, when he was in the emergency department, we had a hypotensive patient who had trauma earlier in the day. The first thing that the emergency physician receiving him did, after confirming the airway and making sure we had vascular access, was to do the FAST exam to look for free fluid in the belly, and that was grossly positive. And so we gave trauma blood and emergently sent the patient to PCEP Southwest with blood hanging. There was actually a nurse sent who could start additional blood on the way. And so he ultimately he did go into hemorrhagic shock, but he was able to be resuscitated from that. His CT showed a grade 3 liver laceration, and so because of all the blood in the belly, he ended up having an ileus. It took him about 8 days to get discharged from the hospital, but he went to rehab. And so this is another really difficult pre-hospital case, and I think what makes this difficult is that one of the things that has to be on your differential is that the doctor that saw the patient in the emergency department the first time missed something. And even if I do my job perfectly, I tell my patients there's generally somewhere between a 1% and 2% chance that there's something that we're not finding today, and so we give them very strict return precautions. And this patient had an initial FAST exam that was negative. The FAST exam is not perfect. If it's positive, it's almost certainly positive, and meaning that the patient almost certainly has at least 500 milliliters of blood in the belly. But with small amounts of blood in the belly, it can miss that. Early in the injury, it can miss that. This guy had a right 7th rib fracture, and so he was primarily complaining of chest pain. But as you know, anytime from the nipples to the groin, you're getting hit in that area, you have to consider blunt abdominal trauma. And so, yeah, this rib fracture here, getting more history, it looks like the bicycle handle had turned around and hit him. So there's actually a fair amount of force right there. And so when you're faced with someone who you do have a history of trauma, patient's unresponsive, hypotensive, tachycardic, just remember that trauma has to be in your differential. And this is not someone who's acting like an opiate overdose. He was given oxycodone for pain, but he's tachycardic. He doesn't have pinpoint pupils. He's hypotensive, which are not typically things that you'd see with an opiate overdose. So it's, but as much as we like to think of ourselves as fantastic, we, even if we do our job perfectly, we miss things, and sometimes we don't do our job perfectly. And typically, if we miss something, you are the first people to see it. Correct. He was a walk-in. Yeah, he was a walk-in to Legacy. Okay. Okay. So a brief review of SUDS. So this is a study to look for the genetic markers of sudden cardiac arrest. So any patient who has a pre-hospital cardiac arrest meets the inclusion criteria. As with ALPS, traumatic deaths or violent deaths are excluded. Overdose are also excluded. You'll draw blood as soon as possible after gaining the vascular access. This is for the transporting agencies. The tube gets labeled, and a hospital faciate is helpful, and then gets placed in the ambulance cooler and into the refrigerator at the headquarters of the transporting agency. That's all we have. Thank you, everyone.